I want to just thank you first off for joining us this afternoon. And I'm really excited for our presenter to be presenting on this topic. First off, I just want to introduce who I am and who we are. So the LOHM, the Ladies of Hope Ministries, is an organization that is working towards ending incarceration and poverty for women and girls who have been impacted by the criminal legal system. We do that through a couple different pillars. One of our pillars is through direct service. So we have housing, food programs, as well as a career development program. Our other pillar is through policy and advocacy work. And with that, we have two programs, our FACES program, as well as our EPIC Ambassadors program. Our third pillar is our health equity program and initiative. And that's really where we're focusing on today. Just to give you a little bit of background around that, we've piloted a program to train 50 women who have been in non-binary folks who have been impacted by the criminal legal system to become birth workers. We had a great successful program with that, and we're gearing up to continue to do that work next year in 2022. This webinar is part of our Repro Justice workshop series that goes along with our doula program and our reproductive justice work. My name is Tanya Hunsey, and I'm an incarceration survivor. I'm also heading up the Health Equity Initiative with the LOHM. It's my pleasure to be here today and to introduce Carolyn Sufrin. If you have questions, I would ask that you put those in the chat or in our question and answer box. With that, I'm going to pass it over.
Thank you so much. I'm really excited to be here with you all today virtually. So before I get started on the content for today, just a brief introduction. So my name is Carolyn Sufrin. I am a white cisgendered woman. I am a physician and I'm also a researcher. I'm based at Johns Hopkins University, which is in Baltimore, Maryland. And so today I'm speaking to you from the stolen land of the Cherokee, the Piscataway, and the Lumbee people. And I myself have never been incarcerated, nor do I have close family members who have been incarcerated. However, I have worked as an OB/GYN at a jail for several years, and I've been conducting research alongside incarcerated and previously incarcerated folks for over a decade. And the research team that I am part of and that I lead at Johns Hopkins, our name is Advocacy and Research on Reproductive Wellness of Incarcerated People. And we've been working for many years to both improve conditions of incarceration and healthcare, reproductive healthcare that folks inside receive, while also advocating for and contributing to efforts to end incarceration of pregnant and parenting folks and all people as well. So that's a little bit about my background. And today I'm going to speak more specifically about, I'm going to share my screen, about policies and research on pregnancy outcomes among incarcerated folks. And sorry, before I get just the requisite, can everybody, or Tanya, maybe you can tell me, do you see my slides? Is everything showing up?
Yep.
Okay, great. So I'm not going to delve into a lot of background on incarceration in general and women who are incarcerated. I'm really going to focus on pregnancy-related policies and outcomes that have emerged from research. But just so we're all on the same page, you know, we know that mass incarceration has disproportionately impacted communities and individuals of color, and that is true whether we are talking about men, women, or transgendered individuals. And we know that the reasons why that the policies that have led to mass incarceration are ones that overlap significantly with violations of the core tenets of reproductive justice, the right and violations of people's rights to have children, to not have children, and to parent in dignity and in safe environments and with the material resources and structural supports needed. So that's you know, by way of very just sort of foundational background that I'm not going to go into much today. And just my disclosure, I do serve on the board of directors for the National Commission on Correctional Healthcare as the liaison for the American College of OBGYNs, and also serve as a consultant for NCCHC for their research arm as well. So the topics that I am going to cover today are the legal basis for healthcare for incarcerated people. What are some of the national guidelines? What policies exist and don't exist? And what kinds of laws address pregnancy and postpartum care for incarcerated people? And then what are some research data on outcomes? And I think I want to just, also foreground why I'm even talking about research. I mean, for one, I'm a researcher, but I believe very strongly that research can be one component of efforts to make change and to advocate to change and ending mass incarceration, especially for pregnant and parenting folks. And so, this is where the background that I have. And so it's important to me that the research that our team conducts is informed by, is led by, is previously incarcerated, and when possible, currently incarcerated folks, and that it's meaningful, that it's, it doesn't just exist there, in publications that academics read, that it's really meaningful and useful for policymakers and for advocates and for people really on the ground. So, so now let's talk about some of the laws and policies. Some of you may be aware of this, but for those who aren't, a really important foundational legal context for healthcare for incarcerated individuals is that the Supreme Court has declared that prisons and jails and other institutions of incarceration are constitutionally required to provide access to healthcare. And this comes from a Supreme Court case from 1976, a landmark case, Estelle versus Gamble, in which an incarcerated individual in Texas who was incarcerated on a prison farm, he injured his back while working on the farm, and he alleged that his requests for medical attention were repeatedly denied and inadequately addressed, and that he was unfairly punished for not being able to continue doing work because his back was injured. And his case made it all the way to the Supreme Court. And Justice Thurgood Marshall delivered the majority court opinion and said that the deliberate indifference to the serious medical needs of prisoners constitutes the unnecessary and wanton infliction of pain prescribed by the Eighth Amendment. So basically, not providing access to healthcare was cruel and unusual punishment. So from this moment on, institutions of incarceration have been constitutionally required to provide healthcare. But if you're scratching your head wondering what this phrase deliberate indifference means and what counts as a serious medical need, well, that you're in good company, because it's not the job of the Supreme Court to say what medical services they must provide. That would be sort of the follow-up activities of policies and other legislation. But because that phrase is so vague, it really depends. Even though there's this basic constitutional requirement, how prisons and jails and other institutions of incarceration interpret what counts as a serious medical need is highly variable. And when it comes to reproductive health care, and including pregnancy and postpartum care, well, it doesn't take much to imagine how easy it has been for those needs to be neglected and sidelined and ignored. So then what does service delivery look like for incarcerated people when it comes to healthcare? Well, there are no required standards. So that serious medical needs, that's all that's out there. And so every prison, every jail, every detention center, they do their own thing. And it may be standardized within a state, or it may not be. It may vary from prison to prison. But jail to jail, there's no centralized oversight. The Federal Bureau of Prisons have a centralized system, and all of their facilities have to abide by their standards or by their policy manuals. But there's not necessarily any required system of oversight. Even if there are standards that, or policies written, there's no requirement that there be sort of an enforcement to make sure they're following those standards. Now, there are a few accreditation programs that exist. The American Correctional Association will accredit healthcare services in prisons and jails. And theirs is not very robust when it comes to healthcare. The National Commission on Correctional Healthcare also has an accreditation program. And, all of these accreditation programs, it's completely optional. So there's not necessarily an overt incentive for people for facilities to become accredited. And beyond that, it's not the end all be all answer for ensuring adequate healthcare. Even the NCCHC standards, while they're certainly better than nothing and they have quality improvement and they're revised every 5 years, there's still a lot of improvement that could happen. It's highly variable what services are available as a matter of routine, what things an individual who's incarcerated could request, and what things are just categorically not available at a particular prison and jail. And there are some prisons and jails that do provide a reasonable measure of access to healthcare services, but many that do not. It's also variable what they can get on site, what people have to be transported off site for. And when it comes to pregnancy care, a lot of institutions of incarceration aren't equipped to provide regular OBGYN or midwifery care. And so transport people off site, or because that might be a barrier, just don't provide it at all. In terms of payment, that's also tricky and variable. Medicaid funding and Medicare, but especially Medicaid for this, for people who are pregnant, it is just categorically not available for people who are incarcerated. And that is built into the law, the amendment to the Social Security Act that was passed in 1965 that established Medicaid. There is a whole clause, it's called the Inmate Exclusion Clause, that is within that policy. And so it can't pay for healthcare for incarcerated individuals. And that's a disincentive in many ways for accreditation and standardization. And so it ends up being the burden, or I shouldn't say the burden, it ends up the cost falls to the individual Department of Corrections, or maybe if their state has an arrangement with the Department of Public Health, but it's not something that they can bill Medicaid for. Now, there is a bill in Congress right now. It hasn't gone anywhere for a long time, but that does propose to lift this Medicaid exclusion clause, or this exclusion clause of incarcerated individuals from Medicaid. And there are also many prisons and jails and other institutions that require incarcerated individuals to pay money to see a healthcare provider at the institution. And that is a huge disincentive. And in fact, it's set up in that way as a disincentive so people don't supposedly abuse the system, which that approach is so fundamentally problematic. People need healthcare and they shouldn't be deterred from seeking healthcare. There are also many prisons and jails and other institutions that contract out their healthcare services to private corporations. Horizon is the biggest. And the privatizing healthcare delivery for incarcerated individuals to a company whose bottom line is about profit, when you're talking about someone's physical and mental well-being, poses a lot of challenges in terms of the quality of care and consistency and the fundamental orientation towards a public health and justice perspective. So really with all of that, it depends what the healthcare that is delivered, how, and the quality, it's really highly variable. So that's some of the service delivery approach. What do national professional societies say about healthcare, especially reproductive healthcare for incarcerated individuals? Well, the American College of OBGYNs is the professional society that I, as an OBGYN, am affiliated with. And ACOG has, especially in recent years, been very active in this area. They were, an early organization to come out against the shackling of pregnant incarcerated folks, and have promoted guidelines and standards of care for this population. They also published position statements at the start of COVID that advocated for the release of pregnant folks and postpartum folks as a COVID mitigation measure. and what healthcare should look like for people until that could happen. And then very recently, just a few months ago, ACOG published an updated guideline of what care should look like when it comes to reproductive health care for pregnant, postpartum, and non-pregnant individuals. And I've included here, and I will be happy to share my slides for your network, but you can also just Google this, ACOG Committee Opinion number 830. But this is a really handy and publicly available document that details many things about what healthcare should look like for incarcerated individuals, and also advocates for alternatives to incarceration. And so to have that in this National Society's guidelines, we hope will be an important advocacy tool as well. But then within the document, it also lists out some bullet points of like, hey, this is the minimum of what pregnancy and postpartum care and other reproductive health care should look like. So this comes directly, it's a screenshot directly from the document, but this is just a sort of quick reference point of like, hey, these are the basic things that should be in place for healthcare. Follow national guidelines. They should get the same standard of care that someone in the community would get, but there are also some unique considerations in incarcerated settings. It includes things about providing access to breast milk expression and breastfeeding. And it also includes a detailed description of the medical risks of restraints. And we hope, ACOG hopes that that's helpful and useful in advocacy efforts at the state level to pass legislation prohibiting the shackling of pregnant and postpartum individuals. So these are really handy resources, and I can go through some of it briefly, but basically it outlines that females who arrive at prisons and jails and other institutions of incarceration should be assessed for pregnancy at intake through a history and their potential for being pregnant, and then should be offered a pregnancy test. It doesn't advocate for requiring it without choice, because people do absolutely have the right to decline healthcare when they're incarcerated, and ACOG supports that. People should be at intake, should be screened if they're postpartum or if they're breastfeeding, so that if they are actively breastfeeding, accommodations can be made to maintain their milk supply. People who learn about a pregnancy, or even if they knew they were pregnant, but they should be, while they're in custody, they should be offered non-coercive counseling about their various options for abortion and continuing a pregnancy and adoption. And they should be provided with access to abortion if that's what they need for that pregnancy. They should get comprehensive perinatal care following the guidelines of the American Academy of Pediatrics and of ACOG. They should be screened for substance use and alcohol use, should be provided access to methadone and buprenorphine, be tested for and treated for HIV. They should receive vaccines in accordance with ACOG guidelines. They should receive screening and treatment for mental health conditions, including postpartum depression, breastfeeding support, adequate nutrition, and if they do go into labor while they are in custody, delivery services should occur at a licensed hospital with arrangements for high-risk pregnancies. And they should also have access to reversible postpartum contraception, not permanent sterilization. Now, the National Commission on Correctional Health Care, I mentioned that they accredit healthcare facilities in prisons and jails. And so they do have a set of standards that in order to be accredited, facilities have to abide by. And there is a standard that has to do with pregnancy. And this is a scanned copy taken directly from the document. And I do note the non-person-centered language that they use at the moment. I will say that NCCHC actually recently adopted a position statement promoting the use of person-centered humanizing language. So hopefully in their next edition of their standards, this one was in 2018, I'm hopeful that the language will be different. But these are sort of the basics that it outlines for care. It includes, something that may not be intuitive, but especially to someone who doesn't provide care inside a facility, that, hey, any facility that houses pregnant people, they need to have emergency delivery kits available. That by no way means that pregnant people should be giving birth in a prison or jail. But, in case labor is rapid, or if, and the EMTs don't get there in time to transport someone, that at least they have the capacity to facilitate a safe delivery. Now, NCCHC also has a few position statements that are publicly available that may be useful for advocacy and also for promoting best practices especially for some of you who may have clients who are incarcerated. NCCHC is very clearly opposed to the use of restraints for pregnant and postpartum individuals. And they also have a really useful position statement on breastfeeding and outlines ways that institutions of incarceration can establish breastfeeding programs and supports promotion of breastfeeding. NCCHC also has a white paper that goes into more detail about what pregnancy care should look like. You can see, full disclosure, I did write this not alone, but just wanted to, even though I'm sharing this resource, I do note that this is something that I wrote with assistance, of course, but it is endorsed by ACOG as well as the National Commission on Correctional Healthcare. This is where you can find it as well. So now moving on a little bit, I'm sure, I imagine this is a topic that that this audience has discussed, and perhaps some of you have been involved in, but the issue of the use of restraints on pregnant and postpartum individuals who are in custody. I do want to acknowledge and thank those of you in the audience who may be active in working to end this practice, the legislative efforts, the on-the-ground efforts, and acknowledging that perhaps some of you may have experienced this indignity and this violation of human rights. And so where does the legislative strategy stand on this? Well, currently, this is current as of a few weeks ago. As far as I know, there are now 35 states, as well as the District of Columbia and the federal government, that have laws that prohibit shackling in labor. The most recent states to pass laws this year are Mississippi and North Carolina. And then the federal government passed a law in 2018 as part of the First Step Act that only applies to people in federal custody, so the Bureau of Prisons and the U.S. Marshal Service. And each of these laws is a little different. The common denominator of them is that it prohibits shackling in labor. That is not the only point at which shackling is dangerous. There are, aside from the fact that it is a flagrant violation of someone's human rights and is against all international standards, including this document from the United Nations, the Bangkok Rules for the humane treatment of women who are incarcerated. And this and many other international human rights organizations have condemned the practice. In addition, all major medical and other healthcare professional societies in the United States have condemned the practice. So aside from the human rights violation of this, the medical risks are many. And I showed you that ACOG position statement that outlines the medical risks, but they include things like inability to provide emergency care and that it can lead to pain, and if someone has swelling and they have handcuffs on, it can lead to falls, which can lead to excessive bleeding. It can lead to all kinds of potential risks. So it is just not a medically safe practice. So, and that's not only in labor, but it's not safe at any point in pregnancy or the postpartum period. But despite the established medical risks, these 35 states that have laws, like I said, the only common denominator is that they prohibit shackling in labor and at the moment of delivery. Some of those laws still allow for the shackling at other points in pregnancy or during transportation to the hospital or to other places, or allow it postpartum. Some laws do not allow it at any point in pregnancy. So it's really highly variable. So you should, whatever state you are in, whatever state you're providing services to clients for, you should know those state laws. And if you want to know where to look look it up. You could just Google your own state, you know, shackling, pregnancy, incarceration, and then your state. But another resource that I'd like to share with you is that our research group's website, RWIP, which stands for, as I mentioned, stands for Advocacy and Research on Reproductive Wellness of Incarcerated People. So on our website, we actually have a resource tab. It has many resources, but one of them is that we keep a living document of state policy or state laws on shackling. And it also includes contact information for the local or the state ACLU. And so we recognize that people who are currently incarcerated have limited access to the internet. But if they do have access, or if their family members do, they can find out information on how to contact the ACLU if their rights have been violated. And then we also have a table, or in this table, it lists whether there is a state law and what that state law is, so that it can be used for advocacy, either in the moment, you know, if you have a loved one who's being affected or a client who's being affected, you know what the state law is. And here's how you can get to it. So now now that I've laid some of the groundwork about some of the policy landscape that's out there, the fact that prenatal care, you know, there's no standards, mandatory standards for prenatal care. We're going to talk about some outcomes and what research data that my team has collected has shown, as well as some other research groups. So one question is just knowing how common are pregnancy and childbirth in custody. And before our research team conducted the Pregnancy in Prison Statistics, or PIP study, which I'll share with you in just a moment, before this, there was really no data about this. There was a survey that the Bureau of Justice Statistics, which is a branch of the Department of Justice, that they conducted in 2002 for jails and 2004 for prisons. And they asked people, and the survey was more broadly about medical problems of people who were incarcerated. And so they did surveys of currently incarcerated people and asked them about medical problems. And one question amid the 50 that they asked was, were you pregnant at intake? So they had one question about pregnancy. And that was, they found that 3% of people in federal prisons, 4% in state prisons, and 5% in jails reported being pregnant at intake. So that's all we had. That's all we had for a very long time, was this, not sort of broad swath, but this sample of people asking them if they were pregnant on intake. But we didn't know how many gave birth. We didn't have updated information, just very limited data. And what I think sort of combining research and advocacy together, and why I do this work is, that absence of data really signals how marginalized and how neglected pregnant folks who are in custody are. If people don't even think to describe the prevalence of it and how many pregnant people there are, it's like they don't count. And then it allows prisons and jails and lawmakers and other policymakers to think that it's not a problem. And so it's really important that we have data so we can show that this is an issue that we need to address, and so that we can have the conversations to change policies, to not only improve pregnancy care, but also to advocate for alternatives to incarceration. So what did we find? What did we do? And what did we find in terms of research? So what our research team did is we conducted a national study to find out what are pregnancy outcomes. We recruited state prison systems and all federal prisons to be part of our study. And what we wanted to do was have prospectively collected data, meaning we didn't want to ask a prison administrator, at the end of the year to say, hey, how many pregnant people were in your facility in this last year? Because if they weren't keeping track of it, they would just probably, give their best guess, and it wouldn't be accurate. So we wanted them to collect data every month and report to our study a variety of outcomes. That way we knew they were tracking it and it was accurate data that we could add up and have it be 1 year's worth of data. So this is a map. The darker purple states are the ones that participated in our study. And you may be wondering, why not all 50 states? Well, it was just it was just me and my research assistant, and we're a small team, and we just didn't have the capacity to collect data from all 50 states. So we sought out the states that had larger prison population, female prison populations, and then through word of mouth, any other state prison system that chose to participate. And through our recruitment strategies, we managed to get 22 state prison systems, including a fairly geographically diverse sample. There were 3 large states that we tried to get to participate, but they declined: New York State, Florida, and California. So unfortunately, we weren't able to collect data from those states. But we did get those 22 state prisons, and then the Federal Bureau of Prisons agreed to participate. So we had all federal prisons. Jails, that's a whole challenge from a research perspective and many other perspectives, but there are over 3,000 jails in this country, and there is no centralized database of how to contact them. So we decided, well, let's at least try the largest jails in this country. So we did get the 5 largest jails and then 1 small jail that wanted to participate. So all in all, the sites that participated in our study represented 57% of females in prisons in this country and 5% of females in jails. And so what we did, we collected data on a monthly basis on how many pregnant folks were admitted to your facility this month. And then at the end of the month, how many pregnant people did you have? How many gave birth? How many had miscarriages, abortions, stillbirths, C-sections, vaginal deliveries, preterm births? How many maternal deaths were there, and newborn deaths? Those were the outcomes that all facilities reported each month. And then we had 2 supplemental sections for 6 months where it was more optional, and facilities reported, we asked them things like how many people with opioid use disorder, how many people had were breastfeeding, how many people had medical, high blood pressure in pregnancy, diabetes, a variety of other outcomes. And lastly, at baseline, we asked all of our facilities to complete a baseline survey about various policies and services and procedures that they had. So what did we find? So in terms of the first level of outcome, which is how many pregnant people are we talking about here? So what we found in terms of the prisons, we found that there were a total of nearly 1,400 admissions of pregnant people to prisons each year. Most of those were to state prisons, so 1,224 admissions of pregnant people to state prisons and 172 to federal prisons. That amounted to 4% of females entering state prisons were pregnant. Now it's hard to extrapolate that up to national numbers because each state has a different population, but we wanted to provide some rough estimate. And so when we did that at a national scale, that extrapolated up to 3,000 admissions of pregnant people to US prisons a year. 3,000. That is not a small number. Even if it were a small number, of course, we should still care and be making efforts to address the needs of this population. But when you're talking to policymakers, that can often be, that number packs a big punch, 3,000. And then when we looked at the jails, in our 6 jails, so 6 out of 3,000-ish jails, there were over 1,600 admissions of pregnant people in 1 year. Now, some of them may have been the same individuals coming into jail multiple times in a pregnancy, but that's many times that a pregnant person is going to need healthcare from the jails. And that amounted to about 3% of females entering jail were pregnant. Again, it's difficult to extrapolate nationally, but we still wanted some estimates. So that amounted to about 55,000 admissions of pregnant people to jails each year. So that's a total of about 58,000 admissions of pregnant people to prisons and jails each year. Again, that number really packs a punch for policymakers to hear that. Sure, it's not, if you're talking about the 2.2 million adults behind bars in this country, yes, that's a smaller proportion of them, but that is still a large number of pregnant individuals who need healthcare. Now, like I said, conducting research that is useful to people and that others can take and run for advocacy efforts is really important to us. So when we published our data, it's open access, it's all freely available, and we published it by state with the raw numbers and the percentages. So all of the states, we published the data that we have so that individuals in different states can look to see where their state is. So in terms of the outcomes, so what happens to these pregnancies, many pregnancies ended behind bars. So up here are some of the main outcomes from our prisons. So we found that there were, in 1 year at the prisons in our study, there were 753 live births, 46 miscarriages, 11 abortions, 4 stillbirths, and 2 ectopic pregnancies. There were no maternal deaths, and there were 2 newborn deaths. And this percentage amounted to 92% of the pregnancies that ended in prison ended with live births, but people also experienced other outcomes as well. And in the jails that were in our study, again, only 6 jails, but this is still worth noting that there were nearly 150 births in just a small number of jails. And that's also, some of them ended in miscarriages and abortions, stillbirths, 4 ectopic pregnancies, also 2 newborn deaths, and no maternal deaths. Again, our data are publicly available according to state. So if it's, I know it's not totally crisp reproduction here in this slide, but you can absolutely find these numbers and these publications through our website. But here's some of the breakdown by states. And we also reported, like I said, C-section rates. So overall in the study, 32% of the live births ended in C-section. That is a high rate of C-section overall. But in general, but when compared to the national average, it's actually spot on. About 1/3 of deliveries in the United States occur via C-section. So it is similar. However, it's really striking that that there's a huge range from prison to prison. And there was one prison where over half of their deliveries were C-section. Same with miscarriages, there was variability. And then preterm birth, 6% is lower than the national rate of preterm birth, which is about 12%, but about 10%. But there's still quite a range. What about some of the other outcomes? We investigated opioid use disorder. We found that there were 117 pregnant people admitted to, this is just for state prisons, who had an opioid use disorder, and that some of them, 81 of them, received medications for opioid use disorder, but 36 of them were forced to go through detox, which is not at all the standard of care, and is, you know, a pretty egregious thing to have to experience while you're in general, but also while you're in custody and also while you're pregnant. In terms of breastfeeding, we found that 11 prisons did allow breastfeeding or pumping, so about half of them, and 5 of our jails, so most of them did have programs in place for breastfeeding, but very few people, very few postpartum people actually were breastfeeding. So there's a lot more going on there in terms of support, getting breast challenges and getting breast milk to infants and that challenge may deter people. We also collected data on where the infants were placed if they were born to someone while in custody. Most of them went to a designated family member, and a few of them, and the second most common one when we did know what happened was that they went into foster care. Postpartum depression in our study was really hard, I think, to measure accurately because we suspect that our facilities were not routinely screening for it. So they only reported 6% of their postpartum individuals had postpartum depression. A recent study just published a few months ago by Howland and colleagues found that of 58 postpartum people who delivered in the Minnesota prison, 2/3 of them had a prior mental health diagnosis, and 1/3 of them were diagnosed with moderate to severe postpartum depression. So I do want to leave time for questions. So even though I do have more data to share, and I will be, I am flagging that I will try to close out my remarks in about 10 minutes, but we do have time for discussion and questions. So abortion is something that we studied in our PIP study, and we found that there were very few abortions that occurred in our study. Only 11 occurred in the prisons, and that represented 1% of the pregnancies that ended in prison. So only 1% ended in abortion, and that's much lower than what we would expect compared to national numbers. Of our jails, interestingly, a much greater proportion, about 18% of those pregnancies ended in abortion, which is very similar to the national averages. So in our jails, at least the 2 jails that were not in Texas, it was something that was comparable to the national rates. So it's very clear from a legal perspective that incarcerated individuals have a constitutional right to abortion. That has been very clearly established, but we know on the ground there's a lot of variability. And my studies and other studies have found that many prisons and jails have restrictive policies where either it's actually in writing that they do not allow abortion, which is just flagrantly unconstitutional, or they have other policies in place that make it functionally very hard for someone to access abortion. Like they require the incarcerated individual to pay for the abortion rather than the prison covering the cost of medical care as they would do for a birth or for most other healthcare services. Or they might require the incarcerated individual to make the arrangements themselves, or they might require them to get a court order, all sorts of things that pose unique challenges. And this is the table from our PIP study of what our study sites, what their policies were about abortion. So most of them did, at least on paper, allow abortion, but many of them didn't even have a written policy. So, for many people, abortion, even though it's their, they have a constitutional right to it, they can't access it because they are incarcerated. So with a lot of these data on outcomes, there's a lot, the PIP study filled in some important data gaps, but there's so much that it did not do. And there's so much that we don't know. We don't know individual level outcomes. So we just collected aggregate data. We asked, prisons and jails to say how many people gave birth. We didn't say, tell us, what was the race or ethnicity, what was the age, what were other medical conditions of that individual. So we really don't have any individual level data, and we need to know that. We need to know that for so many reasons, because each number is an individual, also because of the tremendous racial disparities that we know exist in incarceration and that we know exist in maternal mortality and other adverse maternal health outcomes. We also don't have any systematic assessment of the impact of enhanced pregnancy support services, such as doula support. There are some retrospective studies that have looked at outcomes, but we really need to look at prospective studies. We know that doulas have so many benefits on pregnancy outcomes for non-incarcerated individuals. We have robust data to show that. And we do have some data to show the individual level benefits, the satisfaction, but we really need a more comprehensive assessment to show just how valuable these services are, and that we need to invest even more in those. When it comes to access to prenatal care, that whole backdrop of the variability and lack of oversight in healthcare in general, in carceral facilities, that absolutely applies to prenatal care. So a recent report from the Prison Policy Initiative on state prisons prenatal care policies found that 12 states had no prenatal care policy at all. 12 state departments of corrections didn't have anything to say about prenatal care. And that's just in policy. That doesn't even say what's happening on the ground, because we know there are always gaps in terms of written policies and what happens. And then 24 states had no pre-existing arrangements for what they would do if a pregnant person went into labor or needed to deliver while they were in custody. So the access to prenatal care is really quite variable, and what people get on the ground, who's providing that prenatal care. Maybe it's a certified nurse midwife, maybe it's a women's health nurse practitioner, maybe it's an OBGYN or a family physician. Those are all categories of qualified healthcare professionals, but it may not be. It may be a healthcare professional who has no training in pregnancy care, or it may not even be, it may just be a custody officer who's there to pick up the phone, if you're lucky, to call someone for help. When it comes to shackling, I provided that map to say that, currently 35 states have laws prohibiting shackling of pregnant people who are giving birth. But unfortunately, we know that laws are not enough. It may be one step, it may be one piece of it, but it is not enough. And when advocacy organizations have gone back to evaluate what's happening with compliance with the law, or when we see new lawsuits emerge, or when we have previously and currently incarcerated individuals going public and bringing to light their own experiences, we know that shackling still happens in states with laws, and that is for a variety of reasons. But it's not only about lack of education on custody officers' side, or potentially lack of compassion or caring about people's dignity. We also know that hospitals can be complicit in not knowing the laws, in not treating incarcerated patients fairly. And this study by Lori Goshen and myself and others, we surveyed nearly 700 nurses on labor and delivery units and asked them about, if they know about their state's law, about ethical standards of care, and most of them, and also what they've observed. And over 80% of participants said that their pregnant patients were shackled sometimes to all the time when they came to their hospitals to give birth. So that is pretty egregious. And I think signals, that hospitals can be barriers as well. And also that we know that compliance with laws can be a problem. So there's a lot of work on the ground to change practice. It's not just about changing policy. So in just the final moments, I'm going to provide some data on the treatment of opioid use disorder in pregnancy for incarcerated people, because that's an area that our group is doing a lot of research on right now. We know that the long established standard of care for pregnant folks is that if they have opioid use issues, they should not go through withdrawal. Withdrawal in pregnancy has potential for harms to both the fetus and the pregnant individual. And so treatment with medication, with methadone or buprenorphine, that is the long established standard of care. But there are gaps in that standard of care. And so in the PIP study, we asked, we had 22 prisons and then we had just a handful of jails, but only 18% of the prisons in our study would initiate a pregnant person on medication treatment. And only a third of the jails would initiate treatment. Many of them would continue it if they were on it, in the community, but most of them would not initiate someone on it. And so they would be forced to go through withdrawal. In addition, even at the places that provided medication treatment, and by the way, medication, MOUD stands for medications for opioid use disorder. So even at the places that provided medication treatment in pregnancy, most of them discontinued it postpartum. And I'm going to share some data from jails as well in a moment. But we need to think about expanding that treatment. There are well-established benefits of providing medication in pregnancy, well-established benefits of providing medication in custody. We know that providing people access to medication treatment, it reduces fatal overdoses, both in custody and when people return to their communities. Treatment saves lives. It improves pregnancy outcomes. It improves people's recovery. So many benefits to providing it both in pregnancy and in custody, but it's not necessarily available. So our current research, the RWIP team is currently conducting a multi-phase study, and this one is focused on jails, not prisons, recognizing jails as a unique, or not a unique, but a very particular moment that requires a different kind of services than prisons. And we've surveyed, we conducted a survey of all jails in the US in terms of what is available for pregnant people with opioid use disorder. We've also been conducting qualitative interviews with directly impacted folks, previously and currently incarcerated folks who have this lived experience. And the ultimate goal is to implement a best practice toolkit that's collaboratively designed with directly impacted folks, with people who work in jails, so that, and also people who work in the communities, so that pregnant folks with this condition can get the health care that they need, the life-saving care that they need in a non-coercive and patient-centered, realistic way. So I'm going to share briefly with you some of the data, and then we'll open it up for comments, questions, suggestions, those sorts of things. So I mentioned we conducted this survey, and what we found from 836 jails that responded is that 60% of jails did say they would continue methadone or buprenorphine if someone was on it pre-incarceration, but only a third of them would actually initiate, which means that a lot of pregnant folks are going through withdrawal in our nation's jails. And it was a mix of which medications, methadone or buprenorphine, that's what the N and the B stand for, are available. And then this, again, I think is such a striking and egregious finding, is that even at the places that provided pregnant folks access to medication, most of them forced them to go through withdrawal after they deliver. This is hugely problematic because we know that postpartum is a very high risk time for fatal overdose for people with opioid use disorder. And we know that returning to communities from jail is a very risk time for overdose. So it's dangerous that they force them to go through withdrawal. It's inhumane. Already people are separated from their newborns, and then to have to go through opioid withdrawal. And it signals that the jail only cares about the pregnant person in as much as they're carrying a fetus. It doesn't recognize that opioid use disorder is a chronic condition. And also, in order for someone to, support their parenting, they need to be on medication long-term. This is, just like someone with high blood pressure needs to be on blood pressure medications long-term. Many people need to be on treatment for this chronic condition. So it's really quite egregious that people are forced to go through withdrawal simply because they are no longer valued when they're not carrying a fetus. We also, there's a lot to discuss with our qualitative research with previously and currently incarcerated folks. But I'll just highlight a few themes. We've conducted interviews with 31 people at jails and community treatment programs across 4 states. And basically, none of these findings are surprising, but they are striking, and they will absolutely inform future interventions, which is that incarcerated individuals, even at jails that have methadone or buprenorphine, are not getting accurate or adequate information. They may feel pressured to be on medication without knowing what the implications are, what's going to happen to their babies when they're born, the safety of various medications. And they get misinformation about things like breastfeeding. Breastfeeding is actually not only safe for people on methadone or buprenorphine, but it's actually recommended, and it improves outcomes for the infants. People also, not surprisingly, experienced stigma and judgment and lapses in treatment and care. And many people in our study reported the fears of withdrawal and undergoing forced withdrawal while they were pregnant and postpartum in custody. I know I'm not giving you any time to read these quotes, but these are the data that the sort of summary impressions come from. So I'll just wrap this up so we can have a little bit of time for discussion, and I'll leave these summary points up here. I think the big takeaways are that all incarcerated individuals have a constitutional right to healthcare, but because there's no mandatory set of standards or oversight, it's really highly variable. We need mandatory standards and oversight. We also need to be advocating for alternatives to incarceration and taking the lead from states like Minnesota with the Healthy Start Act. And that research hopefully can help bolster advocacy efforts by providing data that might convince policymakers and others to make change. So thank you very much. And I see there are a few points in the chat box, so I'll open up to that. And then Tanya, if you have any questions you've received, please open it up. Thank you.
Yeah, I just want to be able to just encourage you to ask some questions. This is a conversation. It's really important information, and I know it's a lot to go through so quickly. And we just hope to build community here to be able to fight for health equity for our incarcerated people and people who have been previously incarcerated. So please feel free to ask any questions or make any comments. And yeah, we're really excited about this conversation. One of the things that you had touched on is just really being able to enforce the policies, right? Because we see this all the time, even recently in Minnesota, and it's continuous. This is one of the things that just really gets to me is when we've since 2014, we've had access to doulas and anti-shackling here. And it's a consistent push because we get pushback when they don't follow those, and we'll hear, oh, what was a new charge staff? They didn't know the policy. Well, it's actually the law. And if you are not following this law, what is the accountability, right? And it's so maddening because here it is that we're talking about a population that are incarcerated because they allegedly did not follow the law, and the people who are responsible for them are not following the law, and they get to go home and they get to explain it away with no accountability, no repercussions. That is one of the things that just drives me, it just gets to me. It's like we have to have something in place for when these policies and these laws are not being followed. There was just a case from a jail, from Hennepin County Jail, and that was in the newspaper here, of a woman who was again shackled. She was denied health care when she was going into labor. She wasn't even there for a charge. It was a probable cause, and it wasn't even a felony probable cause that she was brought into jail. She was 9 months pregnant. She started having labor pains. They told her to toughen up and that there was nothing wrong. Then they went ahead and took her after her water broke. They shackled her and brought her to the hospital. They kept her shackled there. And it's just like, this is just recently, and this is something that, it should be an outrage. There should be an outrage. There should be some more accountability, but we know that there's not going to be right now, as much as we push back. One of the things that I at the LOHM have been looking at to look at our healthcare overall is how can we repeal the 1965, I think it was, when it went into law to exclude incarcerated people from Medicaid. And thinking about that in a big way, what can we do? If we can repeal that, we'll be able to look at the Norway model of the import model, right, of bringing healthcare inside from the outside instead of relying on these healthcare companies. It looks like we do have a couple of questions, one in the question and answer and one in the chat.
I see a question. Alma Martinez asked if you can have a copy of the presentation. Absolutely. I'll make sure Tanya has the slides to distribute. And then Alicia Roach asked, who do we even go to make these laws and policies known and have consequences for those that follow? That's the crux of it, right? That's the crux of implementation. And it's going to vary from state to state and hospital to hospital. And there aren't enough strategies that we can test and that's going to work at each site. But you have to start to some degree at sort of the local level. And if there's a jail that has pregnant folks, they're going to take them to the closest hospital. So that hospital, it's incumbent on that hospital, first of all, to make sure their policies are in line with state law, which sometimes they're not, to make sure security officers are trained and aware, and often they're not. And then for that hospital where people will go to birth, either if it's a jail or a state prison, the state prison, usually will have, although there were 24 in that prison policy initiative study that did not, but there's going to be one hospital generally that they take people to. And so they need to work, that hospital, labor and delivery unit, and the emergency department where people also might come, they need to work closely with the prison administration. And I've seen at least one model. I once gave a talk for a group in Jacksonville, Florida, and they had this great collaborative training and sort of not a memorandum of understanding, but the custody officers met with the labor and delivery workers, and hospital policy folks were involved. And it was in the non-stress moment of having a patient, but it was like, okay, let's talk about these scenarios. Okay, this is the law. This is our policy in the hospital. This is our jail policy. What do we do in these situations? And also the familiarity faces helped as well. So I think it has to happen at the local level proactively, where people talk, because also what happens, one of the challenges is all these laws have loopholes, right? That for extraordinary circumstances, like, okay, if, this person is a flight risk, forget the fact that, although birthing people are very strong, like, absconding from law enforcement in the middle of contractions, probably not that significant of a flight risk. Nonetheless, all these laws have loopholes, and people often, in law enforcement often defaults to those loopholes to be the rule rather than exception. So some of that work is about, like, what these are not huge flight risks, and being stationed outside their room, giving them privacy, knowing what to do in that extremely unlikely event, that's what we need to plan for. So that very local level of planning, of not relying on the loopholes. But this was, and I know this was your question, Alicia, who do we go to when it's broken? So from the hospital side, labor and delivery birth workers need to know to go to their hospital lawyers right away in the middle of the night. They are on call. And then you go up the chain of command. It's very hard to do that in the moment, but you do. You can ask to speak to the warden. You can ask at 2 a.m. You go up the chain of command. And sometimes it helps and sometimes it doesn't. You can call the ACLU. That's why our research, I don't know, I don't think they have someone on call 24/7, but that's why we included their contact information in our table. Oh, thanks. Glad that was helpful. And then I see there's one, we're just about running out of time. This is probably a question for best for Tanya, but someone is a DONA certified doula in New York State. What can doulas do to start when there are no programs for doulas for incarcerated people?
Yeah, I can answer that. It's a complicated thing. It's, the state of New York is a very big state. So I would start by, there's a couple different ways that you can start. One, by finding facilities that are near you that you want to work with, and then contacting those facilities and talking to them about being able, like, the benefits of what providing doulas would do for their facility and their Department of Corrections. You have to start to build relationship with them. Can be a very difficult thing when it comes to politics before people, especially when we come from a place of abolition, especially, and wanting to go in, and we know best that the carceral state is not going to be, it's like this battle back and forth. Do I help the system, or am I fighting the system? And so that's one place that you have to come to, of like, how can I work with the system to benefit the people that are currently incarcerated? And then looking at how starting a nonprofit, or if you're going to be working, and how you're going to structure the organization to go in and provide doulas. There's one way of, you can be a nonprofit, you can be a for-profit, you can be an all volunteer based. It really just depends on what you want to do and how you want to work that. I would say you can reach out to myself, because there are in Bedford Hills, especially, I know that there is they're looking at doing doula care there as well. So sometimes it's really about connecting with other organizations in the community, because a lot of times you'll be surprised of other organizations that are trying to do the same work that you're wanting to do already. We just really want to thank everyone, especially you, Carolyn. This has been an amazing workshop, and we will send out the slideshow to everyone. And again, we encourage you to reach out to the LOHM and partner with us in any way possible to bring health equity to incarcerated birthing people. So we thank you again, and hope you have a great day.